Hi everybody, this is the final recording for this topic. We're going to learn about all of the other direct diuretics and finish up then with a couple of other relevant drugs to the urinary system. So I'll really be talking about thiazides and also aldosterone antagonists. Now, in terms of the thiazides, they act on the distal convoluted tubule and they block sodium reabsorption by blocking a sodium chloride co-transporter. So they inhibit the action of that transporter. They are less powerful than the loop diuretics, and that's because of the capacity of the distal convoluted tubule to only reabsorb about 5% of total sodium. However, they are the preferred drugs for treating hypertension as long as there are no renal complications. So they do, in general, have less unwanted effects than the loop diuretics. So that's why they're a preferred drug. But in terms of then, if somebody does have renal complications, they might be switched to a loop diuretic. The thiazides are just as effective as other antihypertensive drugs such as the angiotensin-converting enzyme inhibitors, which we'll talk about in the cardiovascular system topics. So let's have a look at how these thiazides work. So remember, we're talking about the distal convoluted tubule, where about 5% of sodium is reabsorbed from the filtrate back into the blood. So if I just zoom in on the distal convoluted tubule, just showing a schematic of cells lining the distal convoluted tubule walls. You have transporters in the plasma membrane of these cells, and these are sodium chloride co-transporters. So you'll get reabsorption of sodium and chloride from the filtrate across the cells lining the distal convoluted tubule walls into the interstitial fluid. And I haven't put in a local blood vessel there, but back into the blood. So this is the transporter you'd be inhibiting with a thiazide. So if you inhibit that, you're going to inhibit sodium and chloride reabsorption. So it's going to stay in the filtrate. So you're going to get increased sodium and chloride excretion, but also increased potassium, hydrogen, and magnesium excretion too. So that can lead to these sort of side effects of hypokalemia, hyponatremia. If they work too well, hypertension, if you excrete too much free hydrogen ion, alkalosis, and you also get the inhibition of secretion of uric acid as well into the distal convoluted tubule, and that leads to hyperuricemia, and that can promote gout as well. So this question here is just asking what we've covered before: in which part of the nephron is most sodium absorption occurring, and which part has the least. So of course it's the proximal convoluted tubule, where all of the reabsorption is occurring, about 70% of it. And then about 20% occurs then, 15 to 20% occurs then in the ascending limb of the loop of Henle, although remember that it has a capacity to absorb much more. And then 5% in the distal convoluted tubule, and then a little bit of sodium in the collecting duct. Now, thiazide action is limited by the action of endogenous homeostatic control mechanisms. So what does that actually mean? Firstly, what hormone is primarily responsible for regulating sodium reabsorption in the distal convoluted tubule, and what hormone regulates its secretion? Okay, so if you think about it, and we'll go to the next slide here, aldosterone is the hormone that's responsible for sodium reabsorption in the distal convoluted tubule. So here the stimulus for the activation of the renin-angiotensin-aldosterone system is decreased blood pressure. Renin is an enzyme that's secreted from the kidney, and it will catalyze the conversion of inactive angiotensinogen to angiotensin 1, which is then converted to angiotensin 2 by angiotensin-converting enzyme. Now, angiotensin 2, we know, will stimulate the thirst sensation, and it's also a very potent vasoconstrictor, although the effect of angiotensin 2 on blood vessels is fairly short-lived. But it will also cause the secretion of aldosterone, so that steroid hormone from the adrenal cortex, which then travels in the bloodstream to the distal convoluted tubule, where under its effect, sodium potassium pumps will be inserted into cells in the distal convoluted tubule, and that will allow for increased sodium and water reabsorption, which will result in increased blood pressure. And at the same time, it will also secrete potassium into the filtrate. So if we just go back here, thiazide action is limited by the action of endogenous homeostatic control mechanisms. So if somebody has chronically high blood pressure, the body sort of adapts to that and recognizes that high blood pressure as normal. But then if this person is given a thiazide to lower their blood pressure, what will happen then is the renin-angiotensin-aldosterone system will be triggered, and it will then act to increase the blood pressure again. So in this way, the endogenous homeostatic control mechanism, being the renin-angiotensin-aldosterone system, is acting as a physiological antagonist to the thiazide. Similar to the loop diuretics, thiazides will increase potassium, hydrogen, and magnesium excretion, and also decrease uric acid secretion. But the magnitude of these effects seems to be less than with the loop diuretics. For example, because they increase free hydrogen secretion, they can cause metabolic alkalosis. And because they decrease uric acid secretion into the filtrate, that can lead to hyperuricemia and then deposition of those uric acid crystals in joints to cause gout. But this is less likely than with the use of a loop diuretic. There is a difference between the thiazides and the loop diuretics in terms of calcium excretion. So unlike the loop diuretics, the thiazide diuretics will decrease calcium excretion. So there's much less of a risk of osteoporosis with a thiazide compared to a loop diuretic. And in fact, the thiazides seem to upregulate a sodium-calcium exchange pump, and that's why you get less calcium excretion. They also have a vasodilatory action, and the mechanism of that is not fully understood. But if they cause blood vessels to vasodilate, that will also cause a decrease in blood pressure. Now, the thiazides and the loops can be used together, and when they are used together, they have a synergistic effect. So together they increase sodium excretion and water loss more than just the loop diuretics alone. In terms of pharmacokinetics, there are different types of thiazides that differ in their pharmacokinetics, but they are given orally and they're absorbed well across the gastrointestinal tract wall. Tubular secretion will cause them all to be excreted in urine. And these thiazides compete for uric acid secretion. So they're secreted into the filtrate, and they use the same transporter as uric acid does to be secreted into the filtrate. And this is what then leads to the higher levels of uric acid in the blood when somebody is on a thiazide, and leads to that hyperuricemia, which then promotes gout. So they do have some of the same unwanted effects as the loop diuretics have, but the risk is lower with the thiazides. So again, they will cause you to urinate more frequently. That is their mechanism of action. They can cause hyponatremia, so blood sodium levels being too low, and that can lead to dystonia. Hypertension, where the blood pressure drops too much. Hypokalemia, if potassium levels drop too much. Alkalosis, as I mentioned previously, and it's metabolic acidosis, where the pH levels increase too much in the blood. And hyperuricemia then is those abnormally high blood uric acid levels then that can cause those uric acid crystals to deposit in joints. They also have specific unwanted effects that are associated with the thiazides alone. These include reversible erectile dysfunction in some males, can cause hyperglycemia, probably by acting on the pancreas to decrease insulin levels. This possibly increases the risk of renal damage and diabetes, but low doses don't usually cause the hyperglycemia. However, if it does happen, then that excessively high levels of glucose then can cause inflammation in the glomerulus or can bind to the basement membrane and thicken it, and then that will cause renal damage. So the thiazide diuretics are commonly used on their own to treat hypertension, but they're also used in combination with loop diuretics when, there's a need to shift a lot of fluid. So if somebody has severe resistant edema, you can give the combination with the loop diuretics to try and remove that fluid. So we're now going to learn about the aldosterone antagonists. And two very basic questions here. What is an antagonist? And what effect will aldosterone antagonists have? And a hint there is think about what aldosterone normally does. So I think at this stage, everyone knows what an antagonist is. It's a drug that inhibits the action of an agonist. So here, aldosterone is the agonist, and an aldosterone antagonist is inhibiting the binding of aldosterone to its receptor. And inhibiting that will inhibit the formation of or the synthesis of a sodium-potassium ATPase. So that pump that under the influence of aldosterone will be inserted into the intercalated cells of the collecting duct. So by inhibiting that, you're inhibiting sodium reabsorption via that pump, and you're also inhibiting potassium secretion into the filtrate. So these drugs are acting on the intercalated cells of the collecting duct where only 2% of sodium reabsorption can be affected. So these are relatively weak diuretics. However, they still will increase sodium excretion. They are effective antihypertensive drugs. And the benefit of using one of these is they don't come with the same hypokalemia unwanted effect because they decrease potassium secretion. And for this reason, they're known as potassium-sparing diuretics. We'll just look on the next slide at how they're actually working. So these aldosterone antagonists, they're acting on these intercalated cells of the collecting duct. Okay, now just keep in mind that with the more distal parts of the nephron, reabsorption is under hormonal control. Aldosterone acts on sodium reabsorption, and we also have in the collecting duct the action of antidiuretic hormone in terms of water reabsorption. But here we're concerned with these aldosterone antagonists, right? So if we zoom in on these intercalated cells of the collecting duct, what you have to imagine is when blood pressure drops, aldosterone is secreted from the adrenal cortex. It's a steroid hormone, so it freely diffuses into these cells where it binds to an intracellular receptor. And that a series of reactions occur, and that's going to trigger the synthesis of a sodium-potassium ATPase. Okay, and a sodium-potassium ATPase will move 3 sodiums from the filtrate into the blood, and at the same time secrete 2 potassiums into the filtrate. But you're using an aldosterone antagonist here. So the aldosterone antagonist will inhibit the binding of aldosterone to its receptor and therefore inhibit the production of this sodium-potassium ATPase. As a result, you're going to get increased sodium excretion, but you're also not going to get any loss of potassium in the filtrate, because you're not going to get potassium being secreted into the filtrate. And for this reason, they're known as potassium-sparing diuretics. So one of the unwanted effects of aldosterone antagonists is hyperkalemia. So somebody who's taking an aldosterone antagonist would want to avoid taking potassium supplements, because that will make it even worse, and also have their electrolyte levels monitored on a regular basis. And this is particularly important when there's renal disease or when they are co-prescribed with other medications that can increase potassium levels, such as angiotensin converting enzyme inhibitors. GI disturbances are common with these drugs. They can also affect the reproductive systems. Some will interact with receptors for sex hormones, and they do, in some people, produce these estrogen-like side effects, such as development of breast tissue in males called gynecomastia, also testicular atrophy in males as well, and in females, menstrual disturbances as well. As I mentioned, one of the benefits of using these drugs is they can be used in combination with other diuretics to avoid that hypokalemia. So they are often prescribed with loop diuretics or thiazide diuretics for this reason. So common uses for these drugs are as follows. They can be prescribed with potassium-losing diuretics to prevent potassium loss. And this is particularly important when hypokalemia is especially hazardous. So if somebody is also taking digoxin, hypokalemia is very dangerous because that's going to increase the effect of the digoxin. Also used for hyperaldosteronism, where the levels of aldosterone are abnormally high. And in that case, you would have excessive sort of reabsorption of sodium from the filtrate to cause things like hypernatremia and also increased blood pressure. But as well, you would get excessive potassium secretion as well to cause hypokalemia. So that's where these drugs would be useful. They're also used for some cases of hypertension and some cases of heart failure, and this seems to be becoming more common now. So in general, you'd be most likely to use each diuretic as follows. Osmotic diuretics for acute renal failure or for reducing that intraocular pressure before surgery. Loop diuretics for heart failure or severe edema. Thiazides for hypertension. And aldosterone antagonists for hyperaldosteronism or in combination with potassium-losing diuretics to prevent hypokalemia from occurring. Now, very briefly, just talking about other renal drugs, you can use drugs to alter the urine pH to decrease the likelihood of developing those urinary stones that are dependent on particular pHs. So uric acid in acidic pH, and then those magnesium stones in alkaline pH. To decrease the burning sensation of urination and to possibly decrease UTIs, and to increase the excretion of weakly acidic or basic drugs, which we talked about in the pharmacokinetics lecture, but I'm also going to talk about it in the next tutorial. To alter the excretion of uric acid to treat gout, and also to alter the excretion of other drugs as well. Other drugs can be used, say, to treat urinary incontinence. Remember, the smooth muscle in the wall of the urinary bladder is called the detrusor muscle, and it contracts during urination. Acetylcholine is the neurotransmitter that stimulates the urinary bladder smooth muscle contraction. So if you block the action of the acetylcholine, that contraction therefore is reduced and the bladder capacity will be increased. Acetylcholine will act via muscarinic receptors in smooth muscle, and muscarinic receptor antagonists therefore can be used to treat incontinence. And muscarinic receptors, as we know, are found in other tissues. So these other tissues can be affected. For example, cardiac function can be an unwanted effect because it can be affected as well. Okay, everybody, I have finished this topic and finished the whole of the urinary system.